Hello again, good afternoon everyone. This is Dr. Farooq from your ER Skill Lab UK. Today I will speak about intubation. It's a very important topic, and also it's been changing, the practice has been changing over time. As an emergency physician, have you done intubation? What do you call it? Rapid sequence intubation? What type of intubation are you an expert in ED? Have you done intubation in critical care, HDU, anesthesia? What type of intubation we're talking here? First thing, there will be a couple of lectures. It's a big topics to cover in one lecture, but anyway, I'm gonna start today now. Okay, recently I've been trained in Cambridge University on updates on intubation. So I went to Cambridge, at Edinburgh Hospital. I had a one-day course on difficult airway. So I'm going to give you updates, and I believe everybody needs to know emergency, critical care, anyone who is interested to do intubation. So first of all, one of the most important thing of intubation is not just the procedure, is the decision of intubation. The decision of making, okay, now this patient is crashing, I'm going to intubate. Okay? So decision of making intubation is the key. Who is going to make the decision? How and why? Okay? So I will run some scenarios later when I will walk you through on the process of decision making. Okay? So let's say, well, we all agree that this patient needs intubation. Why? Okay, let's say, well, he's in cardiac arrest, of course. He's near death, or he is apneic. Okay, gasping for breathing. So maybe, okay. So if someone is in cardiac arrest already, he needs intubation. And what type of intubation he needs? RSI? No. Rapid sequence intubation is not happening in a cardiac arrest patient when you don't have the time to prepare. Okay? The first thing in intubation is preparation. Okay? If you don't have any time to prepare, we don't call it RSI anymore. No, this is not RSI. In ED, what we see being done is it's crash intubation, because there is no time for preparation. Just okay, there is no pre-medication, there is no muscle relaxant, there is no sedatives, analgesic. Just give me the tube, put it in. CPR is being continued. We have like 10 seconds to do it. This is crash intubation. This is not RSI. Okay. All right. Let's say this is not a crash intubation. This patient is still breathless, is difficult, then we assess how difficult it is. Okay, so there will be some criteria. Okay, so if it is a difficult airway, that is not RSI, that is like difficult airway pathway anyway. And if it is not a difficult airway, then you come to normal standard RSI. Okay, so these are the things we first start to think about. Okay, decision of intubation. Is it a crash intubation? Is it a difficult airway? Is it a planned intubation? Okay, this planned intubation is the standard RSI. I'll walk you through all these steps in my next other videos. Okay. First, let me give you some updates on what's changing. Okay, there is a clinical trial is published in 2019, Journal of American Medical Association. It's an iris randomized trial. Okay, which actually is saying this cricoid pressure is not that effective anymore. I mean, you can ask someone to help you visualize the vocal cords, but regular practice of standard in applying a cricoid pressure is falling out of favor. This, you can keep it in mind that you might not need critical pressure on all the patients. You just need some pressure to help you visualize if it is a difficult one, okay? The second update, I think it's also important, that's once you give all the medications, paralyze the patient, or pre-oxygenation, everything is done, then we just tend to wait until like about a minute or someone when we start to intubate, okay? In that moment, it is advised here, okay? It's one of these, I don't have the literature here, that during that procedure, we need to keep oxygenating this patient with bag valve mask ventilation. And also at the same time put a nasal cannula in with 15 liter oxygen. So two different ways of ventilating the patient, oxygenating the patient, okay, bag valve mask ventilation and nasal cannula at the same time while we're waiting to the sedatives to take effect for about a minute, okay? That's something new. The other one is also, it's, an ideal classical preparation. We know the patient lies supine while we're intubating. Now, this is another article, it's here, I don't have the full article here, it's saying head elevated laryngoscopy position, improving laryngeal exposure during laryngoscopy by increased head elevation. So it's more preferable now to elevate the head end while you're doing the intubation rather than supine, okay? So these are some of the key new things, and also there is something that is being changing in the practice, the medications. So it's emergency departments are now tend to follow the paramedics way of doing medication, okay? So fentanyl, ketamine, and rocuronium, that's the ideal package. So paramedics usually, if it is a stable patient and blood pressure is hemodynamically stable, they use a routine RSI as 3-to-1. So they say, okay, it's RSI, patient is intubated as 3-to-1. What is 3-to-1? Okay. And what happens if patient is hemodynamically compromised? What happens? What medication we're going to give in peri-arrest situation? Okay. So I'll talk you through all these in details with dosage, why things are these medications are preferred nowadays. Okay. And then, of course, I'll discuss more about. So first is preparation. After you declare, oh, this patient needs intubation, and then preparation. Of course, between declaration and preparation, you need to call in for help. If you're alone with a patient, you ask for help. At least 2-3 doctors, expert doctors who are trained in giving, sedation, analgesia. Okay. So one doctor should be assigned for sedation and analgesia. There should be another one doctor or senior nurse trained to help you as an assistant to intubate, okay? There should be someone who can keep an eye on the monitor. Is anything changing in the monitor, can let you know. And there could be another fourth person who would actually help you read something called a checklist. Have you ever done checklist? So it's a checklist. I'm gonna go at some point later. It's a pre-anesthetic checklist. This is the checklist practiced in Edinburgh Hospital, Cambridge University, every time there is an RSI. So this is really important. And also I will discuss about plan for failure. What is plan A, B, C, and D? What happens if plan A fails? Okay, how I'm gonna switch from plan A to plan B or C? How I'm gonna switch from C to D? So there are steps. So anyway, Thanks for listening today, and I hope you will enjoy my intubation lectures, on tracheal intubation in further lectures. Thank you again. I will see you soon.